So let's get started. We are looking at pharmacodynamics and pharmacokinetics. These two topics, each one of them, today we are doing an overview for both of them, pharmacodynamics and pharmacokinetics. But after this class, we'll be talking about pharmacodynamics alone as a topic, pharmacokinetics alone as a topic. So these are very, very important topics, very, very important topics. So let's start with pharmacokinetics. Kin- you know the word kinetic means movement. So you are talking about how the drug is going to be able to move in the body, okay? And it will include these processes, ADME, to include absorption. When you take the drug in your mouth, the blood is in the GIT, the drug is in the GIT. That drug has to be taken from the GIT into blood, that is absorption. And then from blood, it has to go to the rest of the body, that is distribution. And then some of it to actually go to the liver to undergo metabolism, to be activated or deactivated. Actually, the drugs will go to the liver for activation or deactivation, and then M is elimination. Now that the drug has done the work, it has to be removed from the body. So that's pharmacokinetics generally. Pharmacodynamics is what a drug, the D in dynamics is drug. So what a drug does to the body. So we define pharmacokinetics as what a body does to the drug, while pharmacodynamics is what a drug does to the body. Okay, so pharmacokinetics, you can see the steps. You take your drug there, your medicine, it has to be absorbed and then it is gone. So if you take a drug, you answer in the question how it get in, or what we mean by in is inside the blood stream, that is absorption. And then to answer the question how is it broken down, that is metabolism. Normally happens in the liver, it can also happen in the lungs, in the kidney. And then how, where is it going to go, that is distribution. We want it to go to the rest of the body. And then how is, does it leave the body, that is excretion. So understanding pharmacokinetics is going to be important because it is actually the basis on which you are going to be giving doses. Some drugs take a bit of time to be removed from the body. Let's say, for example, a certain drug takes 4 hours to be removed from the body. Like the time that you take it to the time that it is eliminated is 4 hours. So what you do is that if you want to constantly make sure that this drug is working, after 4 hours, give. So you are going to tell the patient, take let's say at 12 hours. After 4 hours, that is going to be at what time is that? At 18, right? From 12 at 16, take again. So that is how you get to give the dosing. So as we have said, in pharmacokinetics, we're interested in understanding this mnemonic ADME: absorption, distribution, metabolism, and excretion. And I've already talked about them really. So how do we apply pharmacokinetics in clinical practice? So for a drug to produce a beneficial effect without intolerable unwanted effects. Remember, if you have got more drug in the body, it it is going to start producing intolerable effects, the effects that a body can tolerate. For example, if a drug takes, let's say, 4 hours to be eliminated from the body, and then you are giving it every after 2 hours, what is going to happen is that it is going to be a lot to accumulate in the body that leads to toxicity. So you need to know pharmacokinetics for you to be able to know uh, the the administration of the drug at the right place, the right concentration, and the right duration. Some drugs, you are going to administer them orally, like someone takes them. Others, we are going to give them via the blood vessels, that's IV, intravenous. Others, it will be intramuscular. Others, it will be sublingual. Others will be by inhalation. And the reason as to why you are doing all this is just to make sure that the patient can tolerate. For example, if someone has got asthma, you want to give mostly inhalation or drugs so that it can only go to the respiratory system and not everywhere else. So that is the right place of administration, the right concentration, and the right duration. Okay, so that is important to know there. Pharmacodynamics is what a drug does to the body. So in pharmacodynamics, you are interested in understanding the same way we understand hormones. When a hormone comes in the body, it is going to attach to a receptor and then activate that receptor. That's the same way a drug does. When the drug comes, it is going to bind to a receptor and then it will open or activate that receptor, and then the action that you want is going to happen. Let's say, for example, the sympathetic nervous system is going to make the pupil to dilate because you are trying to run. So if you give a drug that it works like the sympathetic nervous system, we call those as sympathomimetics, because it works like it mimics the sympathetic nervous system. So what it will do is that when it comes and attaches on the receptor, it will actually attach on the same receptor or even on a different receptor that the actual hormone was supposed to attach, and that results into the action that you want. Okay. So in pharmacodynamics, basically we are interested in understanding drugs and the way they interact with receptors. So the action of the drug is the mechanism by which the drug produces a response in living organism. Mechanism. For example, some of the drugs are going to, let's say, cause the opening of channels. That's the mechanism of action. Okay. And then the effect of the drug is what you see after that channel has been opened. That is a drug effect. For example, penicillins are antibiotics. These ones stop the synthesis of the cell wall. That is the mechanism of action. And the effect is that the bacteria is going to die. That is the drug effect. So the effect is what you see. The drug action is what the drug is doing, like how the drug is really working. So as we have said, mechanism of action is the specific biochemical interaction through which a drug is going to produce its drug action. Some drugs will stop the synthesis of the cell wall. Some of them will stop the synthesis of, let's say, folic acid. Others are just going to cause ions to start entering the cell and leaving inside. That's the mechanism of action. But mode of action is the function or anatomical change resulting from the exposure of the organism to a drug. Like what is going to happen to the structure or to the function of that organism after you give a drug. Some of the organisms will die. That is a mode of action, killing. Others, they will stop to grow. That is a mode of action. All right. So, for example, if you are giving an antibiotic, drugs that fight bacterial infections like penicillins, some of them are bactericidal, meaning that they kill, like suicide. Others are bacteriostatic, they just stop growth, static, not moving. They'll stop growth. So that's mode of action. But mechanism of action is how are you stopping growth or how are you causing death? For example, you are stopping the synthesis of the cell or you are stopping the synthesis of proteins. That's a mechanism of action. Okay. So you can see this diagram represents the relationship between pharmacodynamics and pharmacokinetics. If you administer a drug, the drug is going to be absorbed and is going to go into the systemic circulation. While in systemic circulation, the drug can be metabolized and excreted or it can be distributed. Metabolism and excretion are forms in which the drug can be removed from the body or it can be distributed now going into tissue. These phases here we call them pharmacokinetics. So when the drug now reaches the receptor, it will interact with the receptor and that is going to cause a pharmacological effect. Yes, for example, it will improve the way you are feeling. So that will now be pharmacodynamics there because the interaction with receptors is about pharmacodynamics. When the drug interacts with the receptor, if it is too much, if you have got too much drug, it can lead to toxicity. If it is just enough, it will lead to efficacy. Efficacy is now the effect that we are going to be able to see when the drug is given. Okay. So the relationship between the dose and the effect can be separated. When you give a drug, depending on the dosage of the drug that you have given, it will also determine the effect that you are going to see. Because a certain concentration of drug might not produce a certain response because maybe it is too low. Okay. So you have got pharmacokinetic uh, responses, and then you have got pharmacodynamic responses. Pharmacokinetic, this refers to the dose and the concentration. Remember, kinetic has to do with movement, right? So the higher the dose that you give, the more the concentration that will move through the body. You know why? If you give a small dose, all drugs are metabolized in the body. So it will undergo metabolism, and you're going to see that some of it is broken down. So if I've given a small dose, what you're going to see is that only a small concentration is going to reach saturation. And then pharmacodynamics has to do with the effect, because the concentration of the drug that you have given, the dose of the drug that you give, now the amount that is going to remain to go and interact with the receptor is now the one that will produce the effect. So pharmacodynamics is basically the effect of the drug. So you are saying that concentration is what is connecting pharmacodynamics and pharmacokinetic properties. And this is important. I want you to understand what we're about to talk about now. Please make sure you understand here. Okay? You have got some interesting exam questions. So the time it takes after the drug is administered to reach a concentration that can produce a response is known as the onset of a drug. For example, if you take paracetamol, Panadol, you will not there and then feel nice. Why? Because that drug has first to go into the body and attain a certain concentration. Let's say, for example, to attain the concentration, it needs to produce a response in 2 hours. That's when you start feeling better. That is the onset of action, the time that you are going to start feeling better from the time you administer the drug. Duration of action is how long from the time, how long the drug, the time duration which the drug is present in a concentration large enough to produce a response. Let's say, for example, this drug, it will start working, and when it starts working, you can feel the effect of this drug for, let's say, 6 hours. That is the duration of action. So in that 6 hours, it will be able to protect you, it will be able to make you feel better. When the concentration drops, you will start feeling bad again. That's the duration of action. And then you have got the peak effect. The peak effect is the time it takes for the drug to reach its highest effective action. So you can see when you give a drug here, when you give a drug, you can see the way the graph is going. So at this point, let's say maybe that's after 20 minutes, that's the onset of effect. From the onset of effect until the effect stops to be seen, that's the duration of action. When you produce the maximum effect, that's known as a peak effect. This is when you are feeling way better. If you're having a headache, you can now even go out to start even playing. That's a peak effect. Okay. So when you are talking about the drug response curve, when you give a drug, I want you to understand this, because you know the problem, if you don't understand, you are going to try to be mastering. And mastering doesn't work in me. I think for me, mastering doesn't work for me in medicine, because there are too many complex topics. But if you understand, however much they bring a question, I can answer different questions because I didn't master, I knew. All right, so that's why I want you to know what's happening. If I give a drug, that drug that I've given, let's say this side is representing the concentration, on the x-axis is representing the concentration, and then on the y-axis that is the response. Can you see that if I've not given any drug, I don't have any response? If I give a small concentration of drug, I've got small response. And then there is a certain concentration of drug that I'm going to give that will produce half the desired effect, or half of the maximum effect. That is known as EC50. Okay. And then the maximum point. So there's going to be a point where you reach such that even when you increase the concentration of the drug, you can't produce any further effect, because you have reached the maximum of the effect that you can produce. So any increase in the concentration of the drug here is going to lead to toxic effects. You now start having maybe a headache. This is where someone takes Panadol, a lot of it, because it's of course not a It's not bad. The medicine is okay, but then you've taken it too much such that the excess will now start giving you toxic effects. All right. So this is known as a dose response curve or a drug response curve. Now, normally from this drug, you can see the way it is. We can't get a lot of things the way this drug is. Okay, it's an hyperbola. We can't get a lot of data from it. So what you want to do is you want to find the log of the concentration of the drug. If you find the log of the concentration of the drug, can you see the way the graph has now changed? It now gives you a sigmoidal graph. A sigmoidal graph. So if you take the dose against, so you take the log dose against response, that is going to give you a sigmoidal graph. It's actually a sigmoidal graph that we are going to use pharmacologically because it can give us some properties about a medicine that we are interested in understanding. Without the log of the concentration, we have got a graph that is hyperbolic. Hope that makes sense. After this, I'm going to give you a quiz. We'll see if we are getting it. So this is the hyperbolic graph that we have gotten. So there are parameters that we can get from the DRC, dose response curve, this same curve here. Remember I've said that the response curve we use is the one that is sigmoid after you take the log of the concentration. So the first thing that we get from the dose response curve is the potency. So if we say that drug A is more potent in comparison to drug B, what do we mean? Potency is the measure of the amount of drug needed to produce the response. Okay, measure of the amount of drug. For example, you can have two drugs. For drug A, if I give you 20 milligrams, it will produce the same effect with drug B if I give you 50 milligrams. So since drug A will produce the same effect at a small concentration than drug B, we say that drug A is more potent. So if you are looking at the dose response curve, more potent drugs are found on the left. Can you see the one? So the normal one, the normal graph is this one, which is it in purple, and then on the left, this one in dotted yellow. This drug is more potent than the one that is in blue. Why? Because it will actually produce the same effect like the drug that is in, actually it's even been labeled. This is drug X in yellow, drug Y in blue. So drug X is more potent than drug Y. Why is it so? Because drug X can produce, you can see if I came here, like if I went on the X axis, we are going to have 50% of the response. That is known as EC50, illicit half maximum response. That is half of the maximum response. Half of the maximum response is going to be produced by a small concentration of drug X. And the same half of the maximum response will be produced by a much bigger concentration of drug Y. Does this make sense? Someone say something. I get if we are moving together. So, for example, we can compare, say, morphine. Morphine is an analgesic. It's an opioid analgesic. You can give it if you are feeling pain, but normally you don't prescribe them because of addiction. They make you to feel nice, euphoria. So, for example, you can give 10 milligrams of morphine. It will be equal to 100 milligrams of pethidine. Pethidine is also another analgesic. It's an opioid. It can also help in pain relief. Actually, pethidine is a very good drug, better than morphine, because it doesn't cause what we call uteric colic, and it can be used in pregnancy. So it's a very good. You understand it in neuropharmacology. Is actually going to be the first topic. So in this case, because you can give 10 milligrams of morphine and it is equal to 100 milligrams of pethidine, it means that morphine is more potent than pethidine. So relative potence is defined by comparing the potence of two agonists at which they elicit the half maximal response. Relative, like you have got drug A and drug B, you're trying to compare them. For example, we're going to say drug A is 5 times more potent than drug B. That is the relative potency. I've said that more potent drugs fall where on the left side, because the left side it is representing a small concentration on the x-axis. Another thing that we get from the dose response curve is efficacy. Now, efficacy is the maximum effect that is produced by the drug. Maximum effect. Please, it is not potency. You are trying to see the amount of drug that you should give to have an effect or a response. That response can be maximum or not maximum, but efficacy is the maximum effect produced by the drug. We don't care the concentration of the drug. So for efficacy, you don't look at the x-axis, you look at the y-axis. The higher a drug goes up, the more efficacious it is. So efficacy is actually more clinically important. It's better I give 50 milligrams of a drug and it makes me to feel 100% better than I give 20 milligrams of a drug, I only feel 50% better. So even when the 20 milligrams is more potent, but it is not reaching to the maximum effect. So it is more potent, but it is not more efficacious. So efficacy is better. Okay, hope that makes sense. Another thing that we can look at for a dose response curve is the slope. You can see if the graph has got a much steeper slope, like it goes more up, like A, it indicates that a little increase in dose will markedly increase the response. For example, look at, let's say we are talking about between this point here and just here. Let's say just somewhere here it is 20 milligrams, and then here at 15 milligrams. You can see when you just give that, there's a very big rise in the in the in the graph. That means that that drug is dangerous, because any slight change that you give, there's going to be a very high increase in response. But a flat graph means that even you can see from here, let's say this is 10, up to here, let's say that's 50. You can see there's just a small increase in the graph, in the response of the graph. So such drugs are much safer. Another thing you take from the dose response curve is what we call the therapeutic range. Therapeutic range is also known as a therapeutic window. Please, I want you to understand this. Don't confuse it with the next thing we'll talk about. Therapeutic range is the dose range that produces minimum therapeutic effect and the maximum acceptable adverse effect. Let's explain what we are talking about. If I give a drug, this is a drug I've given you. That drug, there is a smallest, that's a minimum effect that you can have. That's a therapeutic effect. Minimum therapeutic effect. Okay. And then, so have you gotten that? For any drug that you give, you are going to have a very minimum. Like if I've given, okay, you say, okay, I can feel, at least you can feel a bit of different from the way you are feeling earlier. But that's a very minimum best you can feel. Like the very minimum. I felt better, but it is a bare minimum of what you can feel. You can feel much better, but that's the very minimum that you can feel best. Okay, like the minimum therapeutic effect. And then when you give a drug, if you give a higher concentration, you are going to reach to a point where you produce adverse effects, like think bad results now. Let's say, for example, you're taking a drug to help you to calm your headache, but a drug starts making you, let's say, to have other effects like vomiting, diarrhea. So the maximum effect that you can accept, because for the adverse or the toxic effects, the bad things that come from a drug, we can have what we can accept, and beyond that it can we don't accept it. Why? Because it can end up killing us. So the very minimum amount of drug that I can take to feel better, to the very maximum that we can tolerate. Okay, like even when we take it, we're having bad effects, but we can still tolerate them. That difference in dosage is what we call the therapeutic range or the therapeutic window. So the minimum therapeutic effect and the maximum acceptable adverse effect. Okay. So the maximum acceptable adverse effect is also known as the minimum toxic effect, because the toxic effect is the bad things that comes out. So before the drug can become too toxic to kill you, the minimum before it can become toxic to kill you, or the maximum bad things that you can tolerate, that is the same language. That difference is what we call therapeutic range or therapeutic window. Okay, hope that makes sense. So you are saying that the minimum effective dose. So when you're talking about the therapeutic range, you move from the minimum effective dose, which is the lowest dose level of a drug that can provide clinical significance, and then to the maximum tolerable dose, which is the highest dose of a drug that will produce the desired effect without unacceptable toxicity. So up to just only acceptable toxicity, not unacceptable. For example, some drugs, when you take them, you even expect that, okay, when you take this drug, they even tell you, when you take this drug, you'll be feeling like vomiting. Those ones we can accept them, but not you dying. That's unacceptable. Hope you've gotten that. That's a therapeutic range or the therapeutic window. Okay. So the bigger the therapeutic range or the therapeutic window, the safer that drug is going to be. Another thing that we have is known as the therapeutic index, also known as the safety margin. This is a safety margin. So how do we define the safety margin? Safety margin is a gap between the therapeutic effect and the adverse effect, or the concentration of drug between minimum effective concentration and the maximum safe concentration. Okay. So when you give a drug, there is a drug that will make you, there is a concentration that will be making you feel nice, and then the concentration that will make you to have toxic effects. So that difference in there is known as the therapeutic window. The therapeutic window is given. So what's the difference? Therapeutic range. Okay, these are two different terms. Here is supposed to be the margin, not window, right? The therapeutic window, you are talking about minimum therapeutic effect and the maximum acceptable adverse effect. Therapeutic index, you're talking about the median effective dose, the dose that you are going to give, and then it produces half of the maximum response that you want, to the dose that you can give, and then it produces it kills a half of the population that you are studying. And you give this like in rodents or rats. So the maximum amount of drug that you can give and half of the rats die. That's known as a medium lethal dose. And then the amount of drug that you give and half of the population gets better. That's the median effective dose. So the range from the median effective dose to the median lethal dose, that's what is known as the therapeutic index. You can actually calculate by saying therapeutic index is given by median lethal dose, LD50. L is lethal, D is dose. So lethal dose 50 or median lethal dose divided by effective dose 50. That is the equation we use to calculate therapeutic index. Please, if you are not clear between the two, ask. So drugs that have got a low therapeutic range are going to be what? Are going to be monitored regularly. You know why I should monitor drugs with a low therapeutic range is because they are bad. You can see like this graph here. This range here is very big. But maybe let's say this green line, we move it more to the left, and the distance between these two becomes small. So the meaning of that is that the concentration that you need to give to have the effect that you want to the concentration that will produce bad effects is not too different. So that drug, immediately you exceed, you just give a bit more than what you're supposed to give to go beyond the toxic effect, it can kill you. So a narrow therapeutic range means dangerous drug. So you need to monitor that drug very much. Okay. And the relative safety of a drug can be expressed by its therapeutic index. A drug with a narrow therapeutic index is more dangerous for the patient because more increase over normal dose may induce toxic reactions. So that is it, my friends, with an introduction to pharmacodynamics and pharmacokinetics.